So you all agree that we saw the geographical variations, the habits, lifestyle, we treat them, and then prevention is the best way because it is the best cure. Prevention is better than the cure, reduces the burden, financial burden to the country. But once the patient develops the cancer, and what is the role of all of us, which remains common whether you are from Brazil, from India, or from Europe, and that is tertiary prevention. So my talk today is on a tertiary prevention. As a physician, as a head and neck surgeon, what is your responsibility and duty towards your patients once they get cancer and get treated? And that's the tertiary prevention. So my talk today deals on tertiary prevention. I have nothing to disclose. When you see the definition or a dictionary, the tertiary prevention means it's an intervention either to prevent a relapse of the disease after therapy or to minimize therapy-related morbidities. And why tertiary prevention? The survival and the quality of the life after the oral cancer diagnosis depends on the availability and appropriateness of clinical care and rehabilitation. And we saw from Brazil that they don't even have a head and neck surgeon in an area. We are slightly fortunate that we have a head and neck surgeons in most of the part of the country. Despite advances in cancer diagnosis, staging, surgical intervention, multiple disciplinary care, which is followed most of the part, and chemo and radiotherapy available to us, the survival rates for the oral cancer have remained virtually unchanged. And that's the sad part. And that is where our responsibility, because this is our in hand, that we follow up our patients carefully to prevent the second primary. And that is the role of tertiary prevention. The concept of field cancerization, which one of my colleagues said, that it is a presence of field with a genetically altered sense. And that makes the oral cancer more difficult to treat because one area you have treated and he will develop a cancer in another area which is kind of a condemned mucosa. And the oral cancer group of patients are at higher risk of developing second primary, which is up to 20%, despite adequate clearance of the surgical margins at the time of the first surgery. And 90% of the recurrences will happen in the first year of the surgery. And that is where we have to be more aggressive in our tertiary prevention and follow-up. Here is a patient who has a biopsy proven commercial carcinoma of the retromolar trigon here, but you can see the tartars on the teeth, and you can see the leukoplakic patch with the erythroplakia in front. So this is a classical case of a field cancerization. Here is a patient whom I have operated in 2012 with wild local excision and marginal mandibulectomy, but he develops a leukoplakic patch. Here is a scar on the opposite side, and these on a regular follow-up, and which needs to be treated and intervened at appropriate time. And he had to be told to stop the habits. And here is another guy who has been operated 2 years ago with a buccal mucosa cancer with a neck dissection, and in 2 years he developed second primary, which is proven on the lower opposite side. He was operated on this side and he develops a cancer on the opposite side. And this is second primary. So we need to have a very active follow-up, very active kind of a rigorous follow-up, and that is in our hand to our patients to make friendship and to see that they come for follow-up. So this slide explains the field cancerization in a beautiful way by the work of Budwig, and this is normal, but the moment there is a 70p changes, there is a patch, which again with a mutation of the genes causes into field cancerization, and then the last change is 11q, and it develops a cancer. So in a big field, there can be this patch, and this patch. And that is the reason, and that's a challenge we have, what to operate, where to take a biopsy. And these are the patients who will develop cancer in the future, so the need for the secondary good follow-up. Now, main aims of our follow-up is to identify a recurrent tumor or a new primary disease, the provision to help for patients suffering from side effects of the previous treatment, maybe chemoradiation or a surgery, and to identification of patients who need additional help with function like dysphagia, dryness, or mucositis, and some of them could be depressed and psychosocial problems. So these are our main aims of tertiary prevention. Now, tertiary care structure of the services are the support and the rehabilitate the services of head and neck patients, written head and neck plan, rehabilitation plan, and specialized support team to ensure the long-term needs of the patient. So this is a team. This is a team which includes the surgeon, the occupational therapist, the clinical psychologist, nurse, dental surgeons, dietitian, and the maxillofacial surgeons, and the speech and the language pathologist. So this is a team to tackle and it's basically a three-prong approach. And we have all talked that the lifestyle factors play a very important role in the etiology, chemo prevention. My friend from India, my dearest friend from India said that there is hardly any chemo prevention agents, but there is some diet and chemo prevention, and then the rehabilitation of their side effects. So I will be touching on the lifestyle changes and holistic approach, a holistic approach to medical care that emphasizes the study of all aspects of person's health, including physical, psychological, social, economical, and cultural factors. And it is to treat the disease at the root cause, which could be the lifestyle, which could be in his or her lifestyle, or mind-body connection. And I'm passionate about it because I follow this lifestyle, and I'll touch upon few things about it. There's a definite data that it shows that the lifestyle change can beat the cancer, and 30% of all the cancers in Britain were linked to the lifestyle. And in men, it is because of the lack of fruit and vegetables, overweight, and excessive sun exposure. And in women, overweight, infection of HPV, sun exposure, lack of fruit and vegetable, and the alcohol. So we know that these factors are preventable, and that is why there is a definite role of lifestyle changes. Now, these are the risk factors which we all know, but I will be putting it in a right spirit. There are 7 steps of holistic living: nutritious diet and timing of the food. Now, I must say that timing of the food is very, very important. If you all Western people have an early dinner at 6:30, but if you keep eating, say, after 7 or 8, then that's not a good. Or if you have a last meal at about 12 o'clock at night, it is not good, because then your body has a lot of toxins. Prana and breathing, right posture, exercise, sunshine, sleep and massage, secular meditation, and social skill. Now, I'll just touch upon few. The foods to be avoided, which we all know that the food to be consumed is basically vegetables, green vegetables, grilled and baked, not oiled, fruits and juices, food with high water content, and poorly combined and timed meals. The meal should be properly combined and on time. And we all know this pyramid, that the top of the pyramid should be consumed least, and the fruits and vegetables should be consumed more. The prana and breathing, I don't know you understand that yoga is propagated by Indians, and I belong to that country. And a right posture where you can breathe deeply, where your lungs have a better movement of the diaphragm, and you can have a better energy and better immunity. Same thing, the posture should be very important, because the posture in the middle allows you to have a better breathing and less spine problems and body aches. Running and sunshine, extremely important, because it gives you a lot of massage and good sleep, a very, very important factor in your holistic living, which you should encourage. And the secular meditation, which is very, very important. And here is an article which tells you what meditation can tell you, and there are all benefits lined up here, and it definitely boosts your immunity, and you can prevent cancer. So it is to be highlighted to your patients that the better lifestyle is definitely go a long way. And the social skill, of course, needs to be given, because if you are going to be aloof, and you are likely to be unhappy, and you should have a social skill. The chemo prevention is why it is so important in oral cancer, and it has an interest because it is an ideal model to consider these strategies. A well-defined tumor progression model, which I just discussed with you, where the cancer progresses from normal epithelium to mild and moderate and to severe dysplasia to the frank man's cancer. So this is an ideal model for chemoprevention. But unfortunately, as Pankaj said about the targeted therapy, this is a classical model which I mentioned. All cancer prevention agents like this, vitamin A, beta carotene, vitamin E, dietary agents and newer agents have failed. There are conflicting articles in the journal. Retinoids suppress the cell proliferation by blocking the cell site and transition in and inducing atopsis. But there are conflicting agents that there is one study says, Hong study says that the 67% had a clinical response, while the study by Bola said that there is no difference. So there is a conflicting evidences of retinoids. Move to the beta carotene, again contradicting studies. Garewal said that there is a response rate of about 71%, very promising. And Maine et al. Said that there is no advantage in development of second primary tumors. So beta carotene and vitamin A, which are very, very important, has not proved in all the studies. But I personally feel that the dietary agents like fresh fruits and citrus fruits and vegetables, although the extract nutrients of fruits and the mechanism of prevention of oral malignancy is still to be determined, the dietary recommendations to increase fruit consumption and appropriate for preventing oral cancer. So I'm with this theory that it doesn't cost much, it is available everywhere, and you have had to have a habit. The role of curcumin, which is of a great interest, it's an antioxidant, anti-inflammatory and anti-angiogenesis, and it has been used as one of the landmark trial which started with co-investigator Dr. Anil Dicruz from India, and the results were that the inconclusive and inconsistent responses and markers were not standardized. So the result of curcumin, but one can try because again it doesn't cost much. Now coming to the last part of rehabilitation in oral cancer, surgery of the head and neck affects the speech, unintelligible speech, swallowing and salivation causing xerostomia. So these are known side effects of the surgery and major excisions, and functional outcome depends on the extent of the resection and type of the reconstruction done on these patients. So we have a huge responsibility of rehabilitating our patients. The question to be asked is, does this patient has a dysphagia as opposed globus sensation or a xerostomia? Is the dysphagia oropharyngeal or esophageal in origin, or is this dysphagia caused by the structural or functional disorder, and how severe is the dysphagia? Identifying the problem helps because glossectomy will lead to the oral phase of the swallowing. Base of the tongue surgeries will lead to the pharyngeal motility problems. Resection of the facial arches will delay the triggering of the pharyngeal swallow, and lip surgery will lead to the sphincter incompetence. So we have to identify the problem. The mandibulectomy not constructed will lead to the movement of the jaw, and it affects the oral phase. Hard palate and soft palate will lead to nasal regurg or a hypernasal speech. So we have to identify the problem. And then there are maneuvers to this problem. That if it is an insufficient oral transit, then head back position where the gravity will work will help. If it is a delay in triggering of the pharyngeal swallow, chin down will help. And if it is a reduced posterior tongue, base tongue movements, then again the chin down will help because then the tongue pushes towards the pharyngeal wall and it can push the food down. So these are the minor maneuvers which can help our patients. The other strategies will lead to the lingual control exercises, tongue strengthening exercises, thermal and tactile stimulation, and construction of the intraoral processes. For this you need to have a swallowing and speech rehabilitation guide. The xerostomia is the next problem. This is a patient operated by me for tonsil and then radiated 10 years down the line. She has xerostomia. The specialist restorative dentistry and prosthetic expertise is required. The symptomatic treatment is encouraged to drink lots of water, avoid products containing alcohol, sugar, strong flavoring because that will burn these patients. Pilocarpine has helped in the dose of 5 to 7.5 milligram TDS, and artificial saliva, which I find is very good, that when they have to have an active talking, they can use artificial saliva. Here is a patient operated for right ear tonsil radiotherapy 5 months back, and you can see the changes of the xerostomia. And now he complains of dysphagia, And it should not be neglected that this is radiation-induced dysphagia, and a CT imaging shows that he has a second primary in a post-recovery area. So this is our responsibility. Don't neglect your patients and they say, I have a dysphagia, oh, it's related to the radiation. And we must see and hear these patients very carefully. This is a hard palate. This is my very favorite patient. This is my last slide, I suppose. Here is a patient who had a hard palate malignancy operated by me 12 years ago. You can see the radiation changes. He developed second primary, external auditory canal cancer 5 years ago, operated with a cul-de-sac closure, and here is a scar you can see if you don't believe me. And he develops a third primary, a cancer with surgery with a wide local excision, again which is seen that the tongue is resected 2 years back. And he is one of my most favorite patients that is surviving at 80 with 3 malignancy successfully treated. And he is one of my ideal patient of tertiary prevention. He is the incision for the neck dissection which I did for the tongue. So the take-home message is that close follow-up, multidisciplinary teamwork, and ABC of tertiary prevention is the lifestyle changes which I am very, very elucidate. I have spoken in a detail. Chemo prevention by probably diet and curcumin, and rehabilitation of your patients, a long-term morbidity, and making them happy to live the remaining lives they have. And I think it's a team approach, each case with an individualized approach. And thank you very much for patient listening.
Thank you, Dr. Jyoti. You covered a great deal of ground, but I'm grateful to you for bringing us back to basics and even introducing a spiritual element, because that is, of course, very important. And again, it emphasizes that populations are different. Perhaps to provoke a bit of discussion, the emphasis on precancer or leukoplakia or erythroplakia, or what we now choose to call oral potentially malignant disorders, and therefore they might or might not be amenable to chemo prevention, also differs greatly by population. It's important to realize that in the Western world, most oral cancers arise without the patient or a clinician having been aware of a pre-existing lesion. And it's quite a different pathogenesis from the traditional betel quid smokeless tobacco development of cancer that we see in South Asia. So we can take a few minutes, although it's almost 12 o'clock, and thank you to the speakers for keeping to time. If anybody would like to contribute, not just questions, but if anybody would like to contribute a comment, we can take a few minutes to do that.
We really would like, if any questions or any comments from your country you have, we really would appreciate. Any questions or any comments that you have?
There must be some controversies. Do you agree there's a fundamental difference in the natural history in South Asia than there is in Taiwan, than there is in much of Europe? Who believes that oral cancer is always preceded by a lesion that you can see and that you might be able to intervene? So nobody agrees with that. Who agrees with the opposite, that most or many oral cancers arise without a pre-existing lesion? You don't know that either. Who in the room knows their name? Who in the room got out of bed this morning? Gosh, not a very interactive audience. The other thing that I would challenge slightly, which has been said by some of the others, is that there is no improvement in survival rates or other outcomes. In the best resourced multidisciplinary institutions in the world, it is certainly true that survival and outcomes are better, both in terms of the crude measure of survival rates, but also, of course, in rehabilitation and quality of outcomes. So I think as a generalization, we ought to stop saying the survival rate has not improved. It has if the patient is properly managed. And of course treated earlier and so forth. Any of my other co-speakers like to provoke a question or ask a question, make a comment?
Just one comment,
Come to the mic. There's behind you. Or... Thank you for making a comment. I woke you up.
I'm Dakshesh from India. So when I started my career in ENT residency in 2002, I used to see patients of oral cancer aging between 40, 50 or above 50 usually. And then I started career in oncology, surgical oncology first, and then head and neck oncology. And when I started practice, after finishing all those fellowships, and when I started working again in 2011, the age group which I see of the oral cancer is in 30s. And the youngest patient I have treated is not like the madam says like in 12 years, but the youngest patient I have treated is 20 years. And most of the patients, like 50% are less than 40 and other 50 are more than 40. So my question to Dr. Dabholkar or Dr. Chaturvedi, like why we are seeing the decrease in the age group of oral cancer in India?
I can answer this very well. Then Pankaj can answer. The point is, the habits are changing. The pan parag, betel nut is available outside the schools, first. Second is, the stress levels of people is rising. You know, in 30s also, they have a lot of stress levels. And that is why they are having these offending agents and their immunity is not their friend. That is the second most important reason. And third thing is, I think all that what you're talking about prevention, government is doing hardly anything by raising the taxes so that the substance of abuse is not available to them easily, which is a very, very important thing. This substance should not be available to them. That is the reason why the youngsters are getting. And of course, HPV is, which you understand. The media.
Pankaj, you want to make a comment on the regulations? Because one of the things that Dr. Chaturvedi has made an enormous contribution to in India is getting regulation to ban areca nut products in many states. Yes, that's exactly the answer I'd give. There's a good literature which shows oral submucous fibrosis in 5-year-olds and other young people because areca products are being consumed younger and younger. Yes, please.
If I could just make a side comment. We actually, just by experience, thought that there's actually an increasing incidence in young people at Johns Hopkins Hospital and in the U.S. And we actually looked at the data from our data set, and it seemed that, you know, we thought that's what's going on. You know, we're getting a lot of, especially young females in their 20s and 30s with oral cavity, lateral tongue oral cavity lesions. When we actually looked at the data, we were surprised that nothing has really changed.
You were surprised at?
We were surprised, yeah, because we thought on a negative note that's what's going on. But when we actually looked at the data very carefully, the incidence, at least in the U.S., has not changed in terms of the age demographics. Again, this is a different part of the world with different stressors and different carcinogenic exposure. But just, you know, so I'd be careful about generalizing things. I think you have to really look at the data very carefully because you might be surprised, even though you think anecdotally things are changing, they might actually not be. Just a word of caution.
Well, I accept the warning. I think we've all been making that. This is population specific, it's risk factor specific, and oral cancer is a completely different disease to HPV-driven cancer for the most part. And I must say that the data on the prevalence of HPV in South Asia is very contradictory and relatively weak. I mean, it cannot vary from 0 to 100% in different populations between Bangladesh, Pakistan, and India. So I think there are a lot of problems about the technology of what's been used. Yes, sir.
Yes, Brian Lich from Germany. I have one question to you. You mentioned that you are proud that Australia is a part of the world where the HPV vaccination in young boys has emerged and has started. My question is, are there any data really supporting that and giving us a sense of security what we're doing? Or put it the other way, why are you doing it? Do you do that on solid grounds, or do you just do that because you think it might be of help to cut down on the incidence of HPV carcinomas?
More the latter. One of the HPV vaccines was developed in Australia, and we were therefore just up the road from my lab, and we were one of the first countries to introduce a mass vaccination program, and it was directed at teenage girls in secondary school, as it has been done in many other countries around the world. And right at the very beginning, I used to ask the people involved in this, why are we not vaccinating boys? Because clearly, forgive the crudity, they play a role in poking this virus around the population. And that has now been rolled out in Australia. What evidence do we have that's effective? Well, there's evidence out now that the incidence in females, obviously, of cervical intraepithelial dysplasia has reduced in the population. But it is too early to know whether this is affecting the outcome, shall we say, of penile cancer or anal cancer or head and neck cancer in males. But it's a logical thing to do. Do you disagree that it's a...
I do not disagree, but before you go ahead with, let's say, a vaccination program, you have to consider side effects and you have to consider the cost you're imposing on a population. And I think that's why a lot of Western countries
Yes.
in Europe or in the United States, as far as I know, are reluctant to do that vaccination program.
Yes, the health economics of this is fundamentally important, and I can understand that outcome. And if Australia can do it and produce data that it's effective, then that's an encouragement to feed it into your cost-benefit model. So I'm not necessarily saying the whole world should be doing it at the same time, but it's a good thing that somebody is, because the data will become available. Yeah, please. You going to come and make comment? Yeah.
My name is Flavio Grip. I'm from Brazil also. I would like to just mention, we have an important, nice program campaign for larynx tumors. And nowadays we have the International Day of Larynx Cancer. And my question for you that I saw your nice presentation, that in your opinion, for example, Dr. Shane, it's important to make campaign for oral cancer. You have good results. My question is, besides the cost, what could be the good way for us to make a nice campaign, a nice program to decrease the T3 and T4 tumors of the oral cavity cancer to the T1 and T2?
Well, I don't have a...
Early detection and education.
Yeah. Yeah.
There has to be some screening physicians who detect them early and refer to the center of excellence. So that is where the physician's role, because any doctor, any patient will be first seen by the physician. And that physician should suspect, biopsy, or maybe scan it for early, then only you will be seeing the same cases early. It is just not possible to downstage the disease from 4 to 2 or 4 to 1. It is only early detection.
Yeah, this opens the whole area of population screening, and there is another session this afternoon which will deal with this for oral cancer specifically. Most Western countries have looked carefully at the health economics and have concluded that population screening for oral cancer is not cost effective, and it's not done. And there's a Cochrane report, Cochrane review, which says that. There's a US government report which says that. There's no argument to make on a public health basis for general population screening for oral cancer. But in high-risk groups, very much so, and the best data come from the Trivandrum oral cancer screening study in southern India, which show both downstaging and life-saving and cost-effectiveness. That's Shankar and Narayan and co. And the groups in Taiwan that are being examined are at high risk because of the very high incidence. So.
Examination to the physician, to the dentist, why our patients are coming in stage 3 and stage 4 and not in stage 1 and 2.
So what we consistent...
Delay and patient delay, these are the factors which are there.
Yes, true, true. Yeah, yeah.
Diagnostic delay, and once it happens, patient has to arrange for the funds, and by the time he reaches the proper place, it's too late.
Yeah, well, and many Western countries have standards which require no delay as soon as, I mean, we have a 2-week waiting period, and in England, in Britain, we had a 2-week waiting period, and if there was a referral with a question of is this cancer, and that patient were not seen within 2 weeks, the institution was penalized for it. So those standards vary from country to country. I just wanted to finish what I'm saying about screening being cost effective in high-risk groups, but not in the general population. It's to emphasize Dr. Dubulka's point that every primary care clinician and every dentist must examine every square millimeter of the oral mucosa every time he or she has a client. They're not patients, perhaps they're dental patients, but every time they have a client, and that's what we teach. Yes, ma'am.
So I have a question about health education. I'm sorry, I don't remember your name. The professor who's come from Taiwan. You mentioned that there's some rituals. Aborigines, they have their rituals, or people are able to connect to their ancestors through a lot of some of these products, erica nut, betel nut, etc. So I spent some time at the World Health Organization. If someone is coming as an outsider, or even if you're from that country and you're the educated one, how is one able to connect and have this health education and connect with the community and tell them that this ritual may be something that may be harmful? What is a sensitive way for a physician, for a surgeon to do this without seeming arrogant or removing oneself, distancing from the population?
Yeah. Which country did you say? I didn't catch it.
Well, I think the presentation was
Yes.
Taiwan. Perhaps there's something in Papua New Guinea as well that's happening, in
Yes.
certain countries.
Do you want to answer that?
And is there resistance from the population? Do
Yeah,
they accept
actually,
it?
some of the population they dislike our advice, because even we have some media the propagation about this harmful to your health, but actually the patient they did not believe it. This is the patient problem. Yeah.
Right.
Public education by mass media and social media is increasingly important, and because of the restrictions of time, I didn't show you, but I have a couple of video clips of radio and television advertising that we're now running in Sri Lanka. Measuring the effect of that's a rather difficult thing to do down the line. But those are the efforts we have to make. I've argued all along for both top-down and bottom-up approaches, and because the use of areca nut is so embedded in South Asian culture, and you can read about oral cancer in the Vedas, if you can read the Sanskrit, going back 2,000 years, this is so deeply embedded in Indian culture and society. And I think what we would hope by education programs and by government regulation is not to ban it altogether, but perhaps to restrict it to a religious situation. To have areca nut available at a wedding might be perfectly acceptable, but to help people realize that this is not something that's safe 3 or 4 times a day. It's not safe to sleep with the betel quid in your mouth. It's not wise for grandma to chew a bit of areca and give it to the child that she's minding while the parents have gone off to work, because that's why we see submucous fibrosis in 5-year-olds.
Or perhaps to connect with the religious leaders so they
Yes.
could talk to the people.
Yes,
And
and again, there are lessons from the HIV epidemic.
Right.
Because religious leaders in many parts of the world have been the leaders in managing behavior change without stigma in controlling the HIV epidemic. And another anecdote, you mentioned Papua New Guinea. Have you worked there?
No, I have not.
Well, buai, as they call it in pidgin English in Papua New Guinea, can be seen spat all over the pavements everywhere, like we saw from your hospital. And the mayor of Port Moresby was very disgusted by the mess this made, and he sought to legislate cellars off the streets around the whole of the city of Port Moresby because he wanted the city to look cleaner. And we had some considerable difficulty in getting him to take on board that there was also a health promotion message in that.
Thank you.
So, thank you very much for staying the distance, and to all of the contributors for an interesting conversation. Thank you.